General anesthesia. In these lectures, we will let know or get the information about the general anesthesia as we got before the local anesthesia. General anesthesia is a state characterized by first, unconsciousness, 2, analgesia, 3, amnesia and skeletal muscle relaxation, 4, loss of reflexes. The drugs used as general anesthetics are actually categorized into first, CNS depressant, second, induced and terminated more rapidly than those of conventional sedative hypnotics. Well, this diagram actually, the general anesthetics are of two types, inhaled and intravenous. The inhaled one is gas, nitrous oxide is the prototype of it, and volatile liquids such as halothane. While the intravenous one that be injected to the patients actually is also composed of different groups such as barbiturate, such as thiopental, dissociative such as ketamine, miscellaneous as etomidate and propofol, while benzodiazepines such as midazolam, opioid fentanyl, the prototype is fentanyl, is the other type. Well, now we will go to the most important thing in this lecture, which is the stages of anesthesia. Stage 1, analgesia. In stage 1, the patient has decreased awareness of pain, sometimes with amnesia. Consciousness may be impaired, but normally is not lost. This is first stage. Second stage, the disinhibition occurred. In stage 2, the patients appear to be delirious and excited. Amnesia occurs. Reflexes are enhanced, and respiration is typically irregular. Retching and incontinence may occur in this stage. Stage 3, called the surgical anesthesia. In stage 3, the patient is unconscious and has no pain reflex. Respiration is very regular and blood pressure is maintained. While stage 4, called medullary depression, in stage 4 the patients develop severe respiratory and cardiovascular depression that require mechanical and pharmacological support. In anesthesia protocols actually vary according to the proposed type of diagnostic, therapeutic, surgical intervention. All these three parameters controlling the protocol used in anesthesia. For minor procedure, conscious sedation technique that combine IV agents with local anesthetics are often used. These can provide profound analgesia, retention of the patient's ability to maintain a patent airway, and respond to verbal comment. While for more extensive surgical procedures, anesthesia protocol commonly include intravenous drug to induce the anesthetic state, inhaled anesthetics with or without IV agents to maintain an anesthetic state, and neuromuscular blocking agent to effect muscular relaxation. Vital sign monitoring remains the standard method of assessing depth of anesthesia during surgery. Cerebral monitoring, automated technique based on quantification of anesthetic effect on the electroencephalogram (EEG) is also very useful. Well, regarding to the mechanism of action, there's different types of mechanism of action. First, effect on ion channel by interaction of anesthetic drug with membrane lipid or protein, with subsequent effect on central neurotransmitter mechanisms. 2. Inhaled anesthetics such barbiturate, benzodiazepine, etomidate, and propofol, facilitating gamma, which is the gamma aminobutyric acid mediated inhibition at GABA A receptor. These receptors are sensitive to clinically relevant concentrations of the anesthetic agent and exhibit the appropriate stereospecific effect in the case of enantiomeric drugs. 3. Ketamine acts possibly via its antagonism of the action of excitatory neurotransmitter glutamic acid on the N-methyl-D-aspartate NMDA receptors. While most inhaled anesthetics also inhibit nicotine-acetylcholine receptor isoform at moderate to high concentration, 5. The citrikinin-sensitive glycine receptor is another lagging-gated ion channel that may function as a target for certain inhaled anesthetics. CNS neurons in different regions of the brain have different sensitivities to general anesthetics. Inhibition of the neurons involved in pain pathways occurs before inhibition of neuron in the midbrain reticular formation. We will go first with the inhaled anesthetics. The classification and pharmacokinetic of this class. Actually, the agents currently used in inhalation anesthesia are nitric oxide, a gas, and several easily vaporized liquid halogenated hydrocarbons, such as halothane, desflurane, enflurane, isoflurane, sevoflurane, and methoxyflurane. They are administered as gases. Their partial pressure or tension in the inhaled air or in the blood or other tissue is a measure of their concentration. %50 of nitrous oxide in the inhaled air would have a partial pressure of 380 millimercury. The speed of induction of anesthetic's effect depends on several factors. First, solubility. The more rapidly a drug equilibrates with the blood, the more quickly the drug passes into the brain to produce anesthetic effect. Drug with a low blood-gas partition coefficient, such as nitric oxide, equilibrate more rapidly than those with higher blood solubility, such as halothane. The speed of induction of anesthetic's effect depends on several factors. First, solubility. The more rapidly a drug equilibrates with the blood, the more quickly the drug passes into the brain to produce anesthetic effect. Drug with a low blood-gas partition coefficient, such as nitric oxide, equilibrate more rapidly than those with higher blood solubility, such as halothane. The speed of induction of anesthetic's effect depends on several factors. First, second, inspired gas, partial pressure. A high partial pressure of the gas in the lungs results in more rapid achievements of anesthetics level in the blood. This effect can be taken advantage of by the initial administration of gas concentrations higher than those required for maintenance of anesthesia. 2. The inspired gas partial pressure. A high partial pressure of the gas. While here in ventilation rate, the greater the ventilation. However, in circulatory shock, this effect may accelerate the rate of onset of anesthesia with agents of high blood solubility. The more rapid is the rise in alveolar and blood partial pressure of the agents and the onset of anesthesia. 4. Pulmonary blood flow. At high pulmonary blood flow, the gas partial pressure rises also at a slower rate. So here, thus, the speed of onset of anesthesia is reduced. At low flow rates, onset is faster. This is very important. I want you to take a look to it. As the blood flow increases, the gas partial pressure rises at slow rate. Very important. 5. Arteriovenous concentration gradient. Uptake of soluble anesthetics into highly perfused tissue may decrease gas tension in mixed venous blood. This can influence the rate of onset of anesthesia because achievements of equilibrium is dependent on the differences in anesthetic tension between arterial and venous blood. Elimination. One of the most concern of patients and his or her relative is the elimination. Everybody asks when the anesthesia gonna be disappear and the patients wake up. Anesthesia is terminated by redistribution of the drug from the brain to the blood and elimination of the drug through the lung. The rate of recovery from anesthesia using agents with low blood gas partition coefficient is faster than that of anesthesia with high blood solubility. This important property has led to the introduction of several newer inhaled anesthetics such as desflurane, sevoflurane, which because of their low blood solubility are characterized by recovery time that are considerably shorter than is the case with older agents. Halothane and methoxyflurane are metabolized by liver enzymes to a significant extent. Metabolism of halothane and methoxyflurane has only a minor influence on the speed of recovery from their anesthetic effect, but does play a role in potential toxicity of these anesthetics. Well, see minimum alveolar anesthetic concentration, the potency. Now I want you to concern here. We are talking about the potency. The potency of inhaled anesthetic is best measured by the minimum alveolar anesthetic concentration. This is called MAC, defined as the alveolar concentration required to eliminate the response to a standardized painful stimulus in 50% of patients. Each anesthetic has defined MAC, but this value may vary among patients depending on age, cardiovascular status, and use of an adjuvant drugs. I want you to explain this. Regarding to the adjuvant drug, that means the drug is administered with another drug. Estimation of MAC value suggests a relatively steep dose response relationship for inhaled anesthetic. I want you to refer you to my lectures in the stage 3 that I delivered to you regarding to steep dose response relationship to understand what does it mean. MACs for infants and elderly patients are lower than those for adolescents and young adults. When several anesthetic agents are used simultaneously, their MAC values are additive. We will talk now about the effect of inhaled anesthetic. First, on CNS. Inhaled anesthetic decrease brain metabolic rate, reduce vascular resistance, and thus increase cerebral blood flow. This may lead to an increase in intracranial pressure. This is very important. I want you to stress on it. 3. High concentrations of enflurane may cause spike and wave activity and muscle twitching, but this effect is unique to this drug. Although nitrous oxide has low anesthetic potency, that's to say high MAC, it exerts marked analgesic and amnestic action. 2. Cardiovascular effect. Most inhaled anesthetics decrease arterial blood pressure moderately. Enflurane and halothane are myocardial depressants that decrease cardiac output. Isoflurane, desflurane, and sevoflurane cause peripheral vasodilatation. Nitrous oxide is less likely to lower blood pressure than are other inhaled anesthetics do. Well, blood flow to the liver and kidney is decreased by most inhaled agents. Inhaled anesthetic depress myocardial function, nitrous oxide least. Halothane and to a lesser degree isoflurane may sensitize the myocardium to the arrhythmogenic effect of catecholamine. Well, regarding to the respiratory effect, although the rate of respiration may be increased, all inhaled anesthetic cause dose-dependent decrease in tidal volume and minute ventilation, leading to an increase in arterial CO2 tension. Inhaled anesthetic decrease ventilatory response to hypoxia even at subanesthetic concentration during recovery, such as during recovery, of course. Nitric oxide has the smallest effect on respiration. Most inhaled anesthetics are bronchodilators, but desflurane is a pulmonary irritant and may cause bronchospasm. Enflurane, causing breath holding, this effect leads to limits its use in anesthesia induction. For toxicity, postoperative hepatitis has occurred, rarely of course, after halothane anesthesia in patients experiencing hypovolemic shock or other severe stress. The mechanism of hepatotoxicity is unclear, but may involve formation of reactive metabolites that cause direct toxicity or initiate immune-mediated responses. Fluoride released by metabolism of methoxyflurane and possibly by enflurane and sevoflurane may cause renal insufficiency after prolonged anesthesia. Prolonged exposure to nitric oxide decrease methionine synthase activity and may lead to megaloblastic anemia. Susceptible patients may develop malignant hyperthermia when anesthetics are used together with neuromuscular blockers, especially acetylcholines. This rare condition is thought in some cases to be due to mutation in the gene loci corresponding to the ryanodine receptor. Other chromosomal loci for malignant hyperthermia include mutant alleles of the gene encoding skeletal muscle L-type calcium channel. This is the cause for why hyperthermia occurs. The uncontrolled release of calcium by the sarcoplasmic reticulum of skeletal muscle leads to muscle spasm, hyperthermia, autonomic lability. Dantrolene is indicated for the treatment of this life-threatening condition with suppurative management. Now we will talk about the intravenous anesthetics, or the anesthetics that injected into the vein directly. First group is the barbiturate. The prototype of this group is the thiopental and methohexital, have high level solubility, which promote rapid entry into the brain and result in a surgical anesthesia in one circulation time, less than 1 minute. These drugs are used for induction of anesthesia and for short surgical procedures. The anesthetic effect of thiopental are terminated by redistribution from the brain to other highly perfused tissue. But hepatic metabolism is required for elimination from the body. Barbiturates are respiratory and circulatory depressant because they depress cerebral blood flow. They can also decrease intracranial pressure. The group B is benzodiazepine. Midazolam is widely used adjuvantly with inhaled anesthetics and intravenous opioid. The onset of its CNS effect is slower than that of thiopental, and it has a longer duration of action. Severe post-operative respiratory depression have occurred. The benzodiazepine receptor antagonist, flumazenil, accelerate recovery from midazolam and other benzodiazepine. Normally, this flumazenil is used when the toxicity with benzodiazepine, midazolam, and other benzodiazepine drugs occur. While ketamine, this drug produces a state of dissociative anesthesia in which the patients remain conscious but has marked catatonia. Now, what is catatonia? Catatonia is a severe motor syndrome with an estimated prevalence among psychiatric inpatients of about 10%. At times, it's life-threatening, especially in its malignant form when complicated by fever and autonomic disturbance, analgesia, and amnesia. So, this drug produces state of dissociative anesthesia in which the patients remain conscious but has marked catatonia, analgesia, and amnesia. Ketamine is a chemical congener of the psychotomimetic agents phencyclidine. The drug is cardiovascular stimulant, and this action may lead to an increase in intracranial pressure. Emergency reactions include disorientation, 2. Excitation, 3. Hallucination, which occur during recovery from ketamine anesthesia, can be reduced by the preoperative use of benzodiazepine. Opioids, morphine, and fentanyl are used with other CNS depressants such as nitric oxide, benzodiazepine, in anesthesia regimens, and are especially valuable in high-risk patients who might not survive a full general anesthetics. Intravenous opioid may cause chest wall rigidity, which can impair ventilation. Respiratory depression with these drugs may be reversed post-operatively with naloxone. The neuroleptic anesthesia is a state of analgesia, and amnesia is produced when fentanyl is used with hydroperidol and nitrous oxide. Newer opioids related to fentanyl have been introduced for intravenous anesthesia. Alfentanil and remifentanil have been used for induction of anesthesia. Recovery from the action of remifentanil is faster than recovery from other opioid use in anesthesia because of its rapid metabolism by blood and tissue stress. Propofol produces anesthesia as rapidly as the intravenous barbiturate, and recovery is more rapid. Propofol has antiemetic action also, and recovery is not delayed after prolonged infusion. The drug is commonly used as a component of balanced anesthesia and as an anesthetic in outpatient surgery, where it's also effective in producing prolonged sedation in patients in a critical care setting. Propofol may cause marked hypotension during induction of anesthesia, primarily through decreased peripheral resistance. Total body clearance of propofol is greater than hepatic blood flow, suggesting that its elimination includes other mechanisms in addition to metabolism by liver enzymes. The first propofol, a water-soluble prodrug form, is broken down into the body by alkaline phosphatase to form propofol. However, onset and recovery are both slower than with propofol. While phosphopropofol appears to cause less pain at injection site than the standard form of the drugs, many patients experience paresthesia. Intermediate, this imidazole derivative affords rapid induction with minimal changes in cardiac function or respiratory rate and has a short duration of action. The drug is not analgesic and its primary advantage is in anesthesia for patients with limited cardiac or respiratory reserve. Intermediate may cause pain and myoclonus on injection and nausea post-operatively. Prolonged administration may cause adrenal suppression. While regarding to dexmedetomidine, this centrally acting alpha-2 adrenergic agonist has analgesic and hypnotic action when used IV. Its characteristics include rapid clearance resulted in a short elimination half-life. Dexmedetomidine is used mainly for short-term sedation in the intensive care unit setting. When used in general anesthesia, the drug decreases dose requirements for both inhaled and intravenous anesthesia, which is very important. When used in